Hello everyone. Thank you for standing by and welcome to Preparing to Conceive, How to Enhance Your Fertility webinar, sponsored by IsisParenting and presented by Dr. Alice Domar. My name is Becky Morgan. I'm the Pregnancy and Wellness Program Manager here at ISIS, and I'll be your moderator this evening. We also have Nancy Holtzman, who will be in the chat. During this presentation, all the participants will be in a listen-only mode. However, you may submit questions to Dr. Domar at any time by typing them through the chat feature that's located to the left of your screen, or you can direct them to us on Twitter using our handle at ISIS_parenting. You may submit your questions at any time. We'll take questions during the presentation and at the end of the presentation as well. Today's webinar is being recorded, and all of you will receive a link to the recording early next week. So if you miss something or you need to step away to tend to your baby, that's okay, or tend to anything else that's going on in your life at this time. ISIS Parenting is proud to host this evening's webinar. ISIS is the nation's most trusted prenatal and early parenting destination. We provide innovative programs and a highly edited selection of products for expecting and new families in our 4 Boston area centers and online at IsisParenting.com. As I mentioned, I'm Becky Morgan. I'll be your moderator tonight. And it's my pleasure to introduce our presenter for this evening, Dr. Alice Domar. Dr. Domar is a pioneer in the application of mind-body medicine to women's health issues. She not only established the first Mind-Body Center for Women's Health, but also conducts ongoing groundbreaking research in the field. She is currently the Executive Director of the Domar Center for Mind-Body Health and the Director of Mind-Body Services at Boston IVF. She is an Assistant Professor of Obstetrics, Gynecology, and Reproductive Biology at Harvard Medical School and a Senior Staff Psychologist at Beth Israel Deaconess Medical Center. Dr. Domar is the author of numerous books and is a much sought-after speaker, having appeared on The Today Show, Good Morning America, CBS This Morning, Dateline NBC, CNN, PBS, and the CBS and NBC Evening News, just to name a few. She presents lectures and conducts workshops throughout the U.S. and around the world, and her newest book is co-authored with Dr. Susan Love called Live a Little. You may be familiar with her book, Conquering Infertility. Welcome, Dr. Domar.
Thank you so much, Becky. So should I just launch into this? It's interesting because it's a new thing that people can think about where they want to be before they try to conceive. You know, 50 or 100 years ago, when birth control wasn't available, people didn't really have the luxury of, as I said, what to consider before you try to conceive. So I just want to go over this relatively quickly. I am told by my husband that I have a bad habit of speaking too fast. So Becky, I'm deputizing you that if you think I'm talking too fast, I would ask for you to interrupt and tell me to slow down.
I'm on it.
There's actually a study that came out a few years ago that said that people in Boston walk and talk faster than anywhere else in the country. And I'm definitely guilty of that. There's no question that I talk really fast. So, you know, for those of you who have not conceived yet, there are a number of things you want to think about, you know, before you try to conceive. The first, obviously, is probably the most important, which is relationship stability. I mean, do you and your partner feel that this is a good time for the two of you to be bringing a baby into the world? And the reason I say that, I was actually in the position a couple days ago of talking to a couple who ironically had been through infertility and conceived a baby after many years of treatment, and they're coming to see me now because they find their relationship is suffering now that they have a baby. And the fact is, it's an old wives' tale that babies save marriages. And in fact, babies put a fair amount of stress on a marriage. Divorce rates are actually higher in people who have kids. And that's not to say you shouldn't have a baby, because most people feel that having a baby is a wonderful thing. But it's ideal if the two of you feel like you communicate well, that you respect each other, that you trust each other, and that your marriage or your partnership is in a place where you would welcome a baby and that your relationship could handle the stress that a baby will bring. And I'm happy to take more questions about that if people have questions specifically. The second thing is money. Are you financially ready to have a baby? I don't remember what the latest statistics are in terms of how much it costs to raise a baby to age 18. I think it's upwards of about $180,000 or $200,000. And it's not just the cost of diapers. You have to think about, not just the crib and the diapers and everything else, but, are one of you going to stay home with the baby, which means one of you is going to have loss of income, or are you going to, hire a nanny or put the child in child care, both of which are relatively expensive. And so do you feel like each of you, if you both work right now, are at a point in your career where you have money in the bank and you can afford the initial cost of having a baby, and do you have some work flexibility, or are you going to hire child care, which means a pretty significant financial investment? Not to scare you. I mean, obviously, I don't want people to think I'm saying not to have a baby, but these are just things you want to think about. The third thing is family pressure. And I see this a lot in that I'll have couples come in and, when I start talking about, how much do they want to start trying to have a baby, what you hear from the couple is that they're perfectly happy with their life and their relationship, but their family is pressuring them. Either their parents are pressuring them because their parents want to become grandparents, or their siblings might be pressuring them because the siblings have children and they want the cousins to be of the same age, or grandparents might be pressuring them because they want to live to see their great-grandchildren. And so you need to make sure, the two of you are the ones who are going to create this family. And you don't want to get pregnant simply to make your parents happy. This has to be something the two of you want more than anything. And, finally, do you want a baby? It's as one of my friends said after she had her kids, children bring the highest highs and the lowest lows. And so do you want to have a baby? And you have to be able to very comfortably answer yes before you should throw away the birth control. So I'm going to move on to the next slide. And I'm extremely impressed I figured out how to do that. Because I rely on my 16-year-old for technical help. So if the two of you or you decide that you are ready to attempt conception, you want to look at your lifestyle habits, because what you don't want is to have something going on for either one of you that could either make you take longer to conceive or prevent you from conceiving. And so now before you try is the ideal time to look at what your health habits are, and it's a great time to fix things or to change things. So, the first thing is, are you adequately nourished? Do you eat good food? If your habit is to have, a can of Diet Coke for breakfast and to grab a bag of Cheetos at lunch, and then for dinner, you grab pizza, it may be enough calories to support you, but it's not very good nutrition. And for a woman, you really want to make sure that you're eating fruits and vegetables and whole grains and all these things, because what you eat for 2 or 3 months before you get pregnant can actually influence the health of your baby. So it's not just what you eat when you are pregnant. It's what you're eating before you get pregnant. I mean, both things are important, but we don't really think about how we're eating before we get pregnant. You also want to look at what you weigh. So BMI means body mass index, and the normal range for fertility is between 20 and 30. So if you are very thin and your BMI is under 20, or if you're obese and your BMI is over 30, you may want to think about making some dietary and exercise changes so that your BMI falls within that range. And the reason for that is women whose BMI is in that 20 to 30 range, it tends to take them the least amount of time to get pregnant. People in that BMI range have fewer miscarriages. They tend to have less premature deliveries, and they have healthier babies, and their pregnancies go better. So if you're of an age where you have the luxury of waiting a few months until you can get your body mass index into that ideal range, it's probably worthwhile doing that rather than getting pregnant or trying to get pregnant when you're underweight or obese. As I said, it can prevent you from getting pregnant, and so it would be nice to avoid that frustration. A study came out a couple weeks ago showing that women who did moderate exercise actually had the shortest time to conception. And by moderate, I mean things like walking, swimming, not competitive bicycling, things like that. Up until that study came out, I actually told my patients to continue their normal exercise routine, and if they didn't get pregnant within a few months, to think about changing it. But with this new study, we're pretty much recommending to all of our patients that if you want to have a baby, that moderate exercise is the best, which means you don't want to be a couch potato, but you also don't want to be a marathon runner. So again, I would aim for moderate exercise. Nicotine is a no-no both in terms of you smoking, in terms of your partner smoking, and in terms of any kind of secondhand smoke. They've actually literally found nicotine in the fluid that the egg develops. And the last thing in the world you want is your egg or your pre-baby to be exposed to nicotine at that point. Women who smoke literally add 10 years to their reproductive age. So a 25-year-old smoker is as fertile as a 35-year-old non-smoker. So you really want to make sure that there's no nicotine exposure whatsoever.
Dr. Domar, may I interject for a second?
Yeah, sure.
Well, as you're going through these lifestyle habits, there was a question regarding, are these lifestyle issues applicable for women and men?
Most of them actually are. Interestingly, it takes a sperm 2 to 3 months to be created. And so if a man has a not-so-good health habit today, you can actually see it in his sperm for the next 2 or 3 months. Conversely, if a man smokes or drinks a lot of alcohol, for example, and stops it because he wants you to get pregnant, it can take upwards of 3 months before you actually see an improvement in his sperm, which can be frustrating. So if the two of you were thinking about wanting to get pregnant in the next few months, he does need to look at his health habits now.
Thank you.
So the other thing is that if you look at the combination of health behavior, so if you look at the impact of smoking and you look at the impact of alcohol, either one can somewhat reduce fertility in both men and women. But if someone does both of them, it can have a profound impact on fertility. So, one thing is bad, 2 things is really bad, just in terms of getting pregnant and having a healthy pregnancy. Obviously you don't want to be taking any illegal drugs or medications. Herbs, in terms of the herbs you can get at a health food store or the herbs you might get from a Chinese herbalist, make me very nervous. We really don't know what's in these herbs. And so if you see, for example, an acupuncturist or an herbalist who asks you to make a tea, I would strongly encourage you not to do that, because they have found that a fair number of the herbs that are coming here from China are contaminated with lead or mercury, and you do not want to be having lead or mercury in your body when you're trying to get pregnant. So again, it comes down to common sense. Eat good food, don't smoke, exercise moderately, things like that. And finally, in terms of lifestyle habits, you want to make sure that every prescription medication that you take, you review with your OBGYN. We're finding now that more and more medications can not only impact your ability to get pregnant, but can have an impact on the baby if taken during the first trimester. And so, you might think something is relatively benign, but your physician may not. And for example, there's some more recent research showing that ibuprofen, Advil, Motrin, can actually reduce your chances of getting pregnant. So I would review all your medication, not just prescription medication, with your doctor. And again, I'm happy to take questions as I go through this.
Well, I see a question, and
Okay.
This comes up a lot in our childbirth classes for those who are pregnant. So if you might address it to preconception, what about herbal teas, red leaf raspberry, and such?
I'm a conservative, I'd say, maybe not politically, but medically. I'd say if it's a regular tea that you can get in the supermarket, an herbal tea like a fruit-based tea, it's probably okay. I know that every once in a while you see a report, and I know I'd seen rumors of this, and I don't know if there's data to support this, that there was a rumor that this red raspberry tea might increase the risk of miscarriage. And again, I don't know if that's true or not, but given that we're not sure, I would always advise my patients to err on the side of caution. So if it's a fruit-based tea, we actually sell fruit-based teas at the Domar Center, so obviously I feel like some of them are fine. So if it's sold in a supermarket or a health food store as a fruit-based tea, it should be okay. So just a little mini course in reproduction. If you have decided that you would like to conceive a baby, you might want to figure out when is the optimal time to conceive a baby. I mean, honestly, I hate even giving this lecture because what I tell my patients is if you decide you want to have a baby, throw away the birth control, have some fun for a few months, and see what happens. But most of my patients look at me funny and say, no, I want to know exactly when I can get pregnant. So I'm going to go over that. Basically, we think, and there's a rumor out there that women ovulate on day 14. And the fact is, women who have a 28-day menstrual cycle likely do ovulate around day 14. But what is not well known is that you actually ovulate 14 days before you get your period, which means if you have a 28-day cycle, yes, you will ovulate around day 14. But if you have a 30-day cycle, you're actually going to ovulate around day 16. And if you have a 26-day cycle, you ovulate around day 12. So you have to think about your menstrual cycle and count backwards 14 days, and that's about the time that you ovulate. Now, there's a little bit of a discrepancy. Sperm can live in the female reproductive tract for several days. In fact, the rumor is that some sperm can live up to 5 to 7 days, which is why if you don't want to have a baby, you can't be making love around day 9 without birth control, because the sperm honestly can sit and wait for that egg to be released. So if you are trying to get pregnant, making love before ovulation is more effective than after ovulation, because the egg, once it's ovulated, lives a maximum of about 24 hours. So the sperm can live much longer than the egg. And so if you're trying to time your lovemaking, your most fertile days are the day or two before you ovulate and the day of ovulation. One of the most common questions is, okay, how often should you make love if you're trying to get pregnant? I don't think there's actually ever been a study that definitively answered that question. As I said, I think people are sometimes too focused on fertility or infertility before they need to be. And so, as I said, I think you should just make love when you feel like it. If, however, you're feeling like you really want to give this your best shot and maybe you have a month when neither one of you is traveling, the general recommendation is to make love every other day for the 5 or 6 days before you ovulate through ovulation. And that should give you your maximal chance of getting pregnant. So, it's important to know your menstrual cycle. As I said, the average woman has a 28-day cycle, but anything from, 24 to 35 or 40 days is normal. The key is just remembering that 14-day before menstruation is when you ovulate. In the olden days, i.e. until we had these take-home ovulation predictor kits, one way to track to see if you were having a normal menstrual cycle was to take your basal body temperature. I don't think people do that so much anymore because you can get these kits. But if you were to do, and it's a special thermometer that's the numbers are sort of blown up, and you're supposed to take your temperature first thing in the morning before you get up. You tend to have a surge in body temperature before you ovulate, and it stays elevated. And if you get pregnant that cycle, it actually stays elevated into your pregnancy. But if you are not pregnant, it drops right before you get your period. Most women will notice that around the time of ovulation, they have cervical mucus. And the cervical mucus around the time of ovulation looks like egg white. It's sort of stretchy. And so if you see that cervical mucus, it suggests that your hormones are getting ready for you to ovulate, and that's a good time to try to get pregnant. The sperm really like that cervical mucus. They can live in that cervical mucus for a long time. I'm not sure what I meant by cervical position. Becky, did you add that, or did I put that in there?
I may have gotten that off of other websites with the general information to cover.
People ask what position they should use during sex or when they're making love so that they can maximize the chances of the sperm getting to the cervix. And the fact is, when a man ejaculates, the sperm just shoot out of there. And so there's no specific position that you need to try in order to increase the chances of trying to get pregnant. The sperm are going to get to the cervix, and a lot of them are going to figure out how to get through the cervix. So you probably don't need to worry so much about what position you use. As I said, the signs and symptoms of ovulation, some women have what's called Mittelschmerz, which is like a cramping or a little bit of pain when they ovulate, although a lot of women have absolutely no idea when they ovulate. Again, for most people, that egg whitey cervical mucus is a sign of ovulation. Ovulation predictor kits are relatively exact, and so if you've been trying for a few months on your own and you're not pregnant, it's not going to hurt you to get an ovulation predictor kit. I've known a lot of people that used it and got pregnant the first month they used it because they just weren't timing it exactly. How to chart, I would say that if you suspect you're going to need to go see a physician, it does make sense to chart how many days your menstrual cycle is and check off when the two of you make love, and so that your doctor can then go back the 14 days and see if you were making love around the time of ovulation.
Dr. Domar, we have a question. She writes, I have only had one period since I stopped nursing. Is it possible to be ovulating without getting your period?
It's a really good question. You ovulate 2 weeks before you get your period. And so, in fact, yes, you can ovulate and then 2 weeks later get your period. And so there are a lot of women who get pregnant while they're nursing. It's an old wives' tale that you can't get pregnant while you're nursing. And, in fact, I know somebody whose husband's actually a physician, and the physician told the wife, oh, while you're nursing you can't get pregnant, and boom, she got pregnant. And so I think when her baby was about 6 months old, and she was pretty ticked off at her husband. But the fact is, because you ovulate before you get your period, yes, you can be nursing and ovulate and not know it, and you can get pregnant. Any other questions about all this sort of medical, reproductive, high school class 101?
Well, a follow-up to that question is she was wondering if she's not getting her period at all, could she be ovulating? If she's not pregnant and she's not getting the period at all, could she be ovulating?
Again, it's unlikely if she's not getting her period at all that she's ovulating. If she's still nursing, nursing does suppress ovulation, just not 100%. So if she's still nursing,
I believe she's done with that now.
She's done with that. So I would say if you've stopped nursing and within a couple of months you have not gotten your period, it's probably a good idea to check in with your OBGYN because normally once you stop nursing within a few months, your body gets back into a normal cycle.
Thank you.
So why aren't I pregnant yet? I think a lot of people feel like they should be pregnant the first month they try, either because you have a child and that's how easily you get pregnant with that child, or because all your friends brag about that. And I was actually talking to a patient of mine yesterday, and she says, why do people have this idea that it's okay to brag about how long it took you to get pregnant? I just think that's very bizarre. There are a number of reasons why you don't get pregnant immediately. There can be structural problems with either the man or the woman. There can be underlying medical issues, which can include thyroid function, for example. People who have whose thyroid is either too active or underactive may be unable to get pregnant. There's been a lot of research recently about celiac disease, and I think at Boston IVF now we are screening, I think, all of our new patients for celiac disease, which is a gluten intolerance. And the research has shown that women who have untreated celiac disease are more likely to have infertility. And so you need to look at your whole medical history when you try to examine why you aren't getting pregnant. Age can be a factor for both men and women. Obviously, most of us have heard that age affects egg quality, and it definitively does. But there's been more recent research showing that it also can affect sperm production. And so as men age, their sperm tends to be less healthy. And so couples can have infertility because of an age-related male factor, and in fact male age can contribute to miscarriage. And you can go through a whole workup and have unexplained infertility. About 10% of couples never get a diagnosis. They can be treated. There's lots of treatments for unexplained infertility, but you may never know definitively why you aren't getting pregnant.
Dr. Domar, I have a question. She writes, I've been trying to get pregnant for the last 7 months. I've done a 1-month ovulation test for the last 2 months. It looks like I have an LH surge at day 20. Doesn't that mean I ovulate fairly late? And then what does that mean when I have a 27-day cycle?
That's a good question, because if you're having an LH surge on day 20, it means you're ovulating around day 22. And then if you're getting your period 5 days later, it means that if you get pregnant from your ovulation, it probably doesn't give the embryo enough time to implant successfully. So I would say if you really are ovulating on day 20 or 22 and you're getting your period a few days later, it's probably time for you to see a reproductive endocrinologist. That's a fancy word for an infertility specialist. Ovulation issues are probably the easiest infertility to fix and to cure. Women who have ovulatory issues who simply can take medication by mouth for 5 days, and the pregnancy rates are phenomenal. So I would say, again, I'm not a physician, but I think that the best advice I could give you is to see an infertility doctor.
Which segues nicely into the next
perfectly,
slide.
Which doctor to see and when. So if you haven't gotten pregnant, who do you see? And most women start with their OBGYN. And an OBGYN can do some very basic tests, but certainly in Massachusetts, most OBGYNs, if a woman has tried for at least 6 months and she isn't pregnant, most of them will refer that patient to a reproductive endocrinologist, mainly because reproductive endocrinologists have a lot of training. They've gone through an OBGYN internship and residency, and then an additional 3 years of fellowship training specifically how to treat infertility. And so we're very lucky in Boston that there are so many good reproductive endocrinologists here. And so my bias always is to see a reproductive endocrinologist sooner rather than later. Although if you live somewhere where it's more rural and there's no reproductive endocrinologist, then certainly I would start with your OBGYN. If a male factor is identified, your husband or partner should see a urologist. Ideally, there's a subspecialty of urology called andrology. And an andrologist, his expertise is treating male factor infertility. So if you have that access, I would definitely try to do that. If you have a pre-existing medical condition that might impact your fertility, such as endometriosis, or if your partner had, for example, a history of mumps as an adult, you probably want to see your physician right away, because anything that's pre-existing that could affect your fertility, you want to address and hopefully fix so that you can try to get pregnant as soon as you can. And then the question is, how long should you try based on your age? The current guidelines, I can't see, is that on the next slide? I can't remember. Nope, I'll go back to previous slide. The current guidelines show that if you don't have a pre-existing medical condition, if you're under 35, you can try for up to a year before you see a doctor. If you're 35 to 40, you should only try for about up to 6 months before you see an infertility specialist. And if you're over 40, the recommendations are that you only try for up to 3 months before you see an infertility specialist. And the reason for that is, if you're not pregnant after a year, I actually just saw this data this morning. I think 86% of women will be pregnant within a year of trying. And so if you're not pregnant after a year, if you're one of the 14%, it probably makes sense to see a doctor so they can get the process started sooner rather than later. So if you decide to go see an infertility doctor, what do you expect at the first appointment? Both of you should attend, because it takes 2 people to make a baby, and there's no way of knowing if the female has a diagnosis, if the male has a diagnosis, or if both of you have a diagnosis. And so both of you need to attend to see the infertility doctor, who will take a medical and reproductive history from both of you, because both of you are equally important. In all likelihood, both of you will have physical exams, and the doctor will schedule blood work, a semen analysis, and other tests. If your doctor, most doctors will have the woman have a blood test on day 3 of their next menstrual cycle. It's called, day 3 bloods is sort of the lingo. And what it means is the day you get your period is day 1. So let's say you get your period on a Monday. You would need to come in for a blood test on that Wednesday. And the timing is really important. If your physician orders day 3 bloods, you need to make sure you go in on day 3. because the only way that your doctor can assess how accurate they are is if they're the exact date that he recommended. What they test for when they assess your fertility is LH, is called luteinizing hormone, and that is the hormone that's released during the first half of your menstrual cycle. TSH is thyroid-stimulating hormone. As I said a little while ago, thyroid function is absolutely crucial for fertility. And if your thyroid is off, it can actually increase your chances of having infertility or having miscarriage. And so your doctor has to make sure that your thyroid function is entirely within the normal range. FSH stands for follicle-stimulating hormone, and this is the hormone that your body produces during the first half of your menstrual cycle. It is a very rough estimate of how many normal, healthy eggs are in your ovaries, and it's a pretty important test. So if your FSH is significantly elevated, your doctor is going to take a relatively different approach than if your FSH is in the normal range. And that's a hormone that really has to be measured on day 3 of your cycle. That's where all the parameters are. Prolactin can impact ovulation, and testosterone for both men and women has to be measured. Testosterone production can affect sperm production. And so it's very likely if there's an issue with a semen analysis that the doctor will ask for blood work for the man as well. The male partner will be asked to do a semen analysis. Depending on where you live, he can either collect the sample at home and bring it in, or he can collect it at the clinic. I understand that men don't enjoy this. They don't like this. It's a relatively innocuous thing. Certainly I know at Boston IVF we try to make it as non-embarrassing as possible for the men, and we have videos and magazines, and we try to make the men as comfortable as they can. When you do a semen analysis, you're looking for a number of different parameters. The first is the count, which is how many sperm are in the ejaculate. They also look at motility, which is the ability of the sperm to swim forward in a normal direction. And then finally, morphology, which is the percentage of normal sperm. So the head and the tail have to be shaped normally. And they look at those 3 things. And if any one of those is abnormal, then the male partner is considered to have male factor. As I said earlier, you can have just male factor diagnosis, just female diagnosis, or both of you, so that both of you might be subfertile. A laparoscopy.
Dr. Domar.
Yeah.
Oh, I apologize. Is there a particular order, and I know you're going through the rest of the tests, but is the semen analysis usually called for at the same time as the blood work?
Yes.
Or
there's some basic things that really need to be done after the first visit. One is the blood work for the female partner on day 3 of her cycle. The second is a semen analysis of the male partner. And then the fourth bullet, hysterosalpingogram, which is a very long word. It's abbreviated HSG. And those 3 things have to be done right away, because those give you the most basic information that your doctor is going to need to make a decision of what the next step is. Laparoscopy is actually a surgical procedure. It used to be done on all infertility patients as part of the basic workup, but I know certainly at Boston IVF they do not do laparoscopies as part of the diagnostic process for every patient. If a woman reports symptoms that were indicative, for example, of endometriosis, they may decide to do a laparoscopy, but it's definitely not routine anymore. The hysterosalpingogram, or HSG, is done on all women. It's a radiological procedure where you inject, or the radiologist, or the infertility doctor injects dye through the cervix, and the idea is to see if the uterus is normal and if the tubes are open. And so a normal HSG means that the woman's uterus is normal and both of her tubes are open. Based on what the HSG shows, your physician may decide, for example, to do a laparoscopy. So if both tubes are blocked, or if they see other things on the HSG, they may decide to do a laparoscopy. But a normal HSG tends to mean that she's not going to need a laparoscopy. And then the physician may order other tests based on your history or based on what these initial tests have shown. So there are lots of treatment options. What I'm hoping everybody is going to walk away from this webinar is that most people who are treated for infertility do end up getting pregnant. So if you haven't gotten pregnant within the 3 months or 6 months or 12 months based on your age and you see an infertility specialist, if you stick with your doctor, you are more likely to get pregnant than not. And as I said earlier, some of the medications are as easy as taking a pill for 5 days. IUI is intrauterine insemination, where they basically take a semen sample and they can prepare the sperm in such a way that they can just thread a catheter around the time of ovulation through your cervix and basically drop the little swimmers in your uterus, and it gets them more than halfway there. And you can do an IUI with or without medications. If the preliminary treatment hasn't worked or you have a diagnosis of severe male factor or potentially blocked tubes, your physician is likely to suggest in vitro fertilization. And the bad news is people think, oh my God, IVF. But I have to tell you that the pregnancy rates per cycle with IVF are incredible. For most women, they're looking at, depending on her age, about a 40% chance per cycle. And Mother Nature is not nearly that good. So the field has gotten far, far better than Mother Nature.
Don't get in trouble with Mother Nature on this.
Sorry about Mother Nature, but I think the average couple when they first start trying has about a 20% chance of getting pregnant, and with an IVF cycle, for a lot of people, we're looking at twice that. So I think I should feel proud to be part of a field that's made that kind of progress. And there are variations of IVF. If there's a severe male factor, they do this thing called ICSI, where they can actually inject one sperm into each egg. It's highly successful treatment for male factor. If the diagnosis is that the woman's eggs are not healthy or normal, they can offer her donor egg. This tends to be offered to women on the higher age range of people who want to have a baby. It's relatively rare for a really young woman to need donor eggs. And then IVF with blastocyst transfer, most IVF cycles, they transfer embryos when they're 3 days old, but with the new technology, they may be more likely to transfer them at 5 days because that tends to decrease the risk of twins and triplets. In my field, our goal is one healthy baby. Twins, I know, delight a lot of people, but the goal really is one healthy baby. As I mentioned, if your doctor thinks that there is an issue that might need a laparoscopy or hysteroscopy, he will order that. He or she will order that. Another option, which is probably the least expensive option in terms of the true high tech, is if neither you nor your partner produce normal eggs or sperm, there's now donor embryos. So people who have done an IVF cycle and have had as many children as they want donate their embryos, and they're agencies that will be the liaison so that you could receive these donor embryos and get pregnant with them. And then finally, surrogacy. If the woman has a uterine problem or she's a medical condition where she can't be pregnant, she and her partner would create embryos. So it would be the woman's eggs and the men's sperm, and you combine them to make embryos. And then you have what's called a gestational carrier, who's a woman who has a history of delivering healthy, normal babies, and you basically hire her to carry your pregnancy for you. You tend to have very high pregnancy rates with surrogacy, which is...
Dr. Domar, there was a question about medication.
Yeah.
About does Provera stimulate ovulation?
That's a medical question, which I would be more comfortable having a physician answer, but I do know that some patients who don't get their periods naturally, their physician might recommend that they take Provera to induce menstruation. And
another medication question, if I had to take Clomid with my first pregnancy, is it likely that I'd have to do the same thing to get pregnant again?
The answer to that, again, it's a medical question, so I get a little nervous answering them. It probably depends if you have the same symptoms now that you did. So, for example, there's some women who don't get their periods unless they take medication, and maybe they don't ovulate or menstruate on their own. And so if you give these women Clomid, it induces ovulation. So if she is, had a baby and now isn't getting her period again, or she still isn't getting her period, then in all likelihood she might need to get treated with Clomid. But sometimes pregnancy seems to fix things. I can't tell you how many patients I've had who needed to have medication or IVF or something to have their first child, and then very easily conceived a subsequent child. So depending on what her medical situation is, she may or may not need to take Clomid again.
Thank you.
So then there's also, the field that I'm in, which is integrative care. What are the options? I have to keep my scientist hat on. I know that makes me sound like a geek, but if you look at the data on acupuncture, there is not a huge amount of data on acupuncture to treat infertility. In China, that's actually the treatment of choice, and so there have been a lot of records of acupuncture inducing ovulation. But in this country, the best data is using acupuncture as part of an IVF cycle, and it looks like acupuncture does increase pregnancy rates. I personally am a huge believer in acupuncture. It's cured me of sinus infections and pulled muscles and back pain and such. And so I do recommend to my patients that if they're having a problem getting pregnant, to give acupuncture a try. Nutritional counseling is vital if their BMI is under 20 or over 30, as I said, because then you're less likely to get pregnant and more likely to have pregnancy complications. And so it's important to sit down with a nutritional counselor or dietitian who can actually work with you to eat in such a way that your BMI gets into a more ideal range. Also important is if you have a history of PCO, which is polycystic ovarian syndrome. It's really hard to figure out how to eat well if you have PCO. Patients who have PCO are hungrier than people who don't. They tend to have more cravings, and they tend to metabolize carbohydrates differently. So if you have a diagnosis of polycystic ovarian syndrome, I would strongly encourage you to see a nutritionist. Emotional counseling, there is data to show that anxiety and depression can suppress fertility. Probably depression is stronger data than anxiety. So I'd say if you've been trying to get pregnant and you feel overwhelmed by either the infertility or just things in your life, I know I'm biased because I'm a therapist, but I think it would be a good idea to see someone and see if you can get yourself back on a more even emotional keel. Yoga, chiropractic care, and hypnotherapy are all things that I would say if they feel good, do it if you enjoy them, but there's no data per se that they increase fertility. Mind-body programs, however, there is data. There's been a number of randomized controlled studies showing that women with infertility who participate in a mind-body program have higher pregnancy rates and significantly less physical and psychological symptoms.
Dr. Domar,
yeah.
Could you take a moment for those who are in the Boston area to speak a little to the mind-body programs that you offer at Boston IVF?
Oh, of course, I'd be more than happy.
Well, I thought I'd set that up for you.
I just love to plug the program. I started the Mind Body Infertility Program 25 years ago. Actually, in September it'll be 25 years. And basically, it's a group program for women who are going through infertility. Your partners are invited to attend 3 of the 10 sessions, and you learn everything you need to know to get your life back, to become the person you were before infertility. So you learn a lot of relaxation techniques, and you learn stress management strategies, and you learn which lifestyle habits you might want to think about changing. And you do all this in the company of people who know exactly how you feel. So you can walk in and say, my sister just told me she's pregnant for the 3rd time, and everyone in the group goes, oh, we're so sorry. Because that's sort of how you feel when you go through infertility. The data we've published, I published a number of studies. Last year we published a paper showing that even with IVF patients, when they do a mind-body program, they more than double their pregnancy rates. So there really is solid data that mind-body programs do increase pregnancy rates. So I would say if you're experiencing infertility, I would strongly encourage you to do a mind-body program. And thank you, Becky, for allowing me to brag a little bit.
Oh, that's fine. I've heard so many wonderful things about the program, so I don't feel like it's plugging. I feel like it's really important information to get out there.
Thank you. In terms of research, I think I've actually mentioned all this research. I'll just spend 2 seconds because I want to leave some time for questions. What is the impact of stress on fertility? It does look, as I said, that depression can hamper fertility. Anxiety can probably hamper fertility. And so if you're trying to get pregnant and you're feeling pretty stressed, especially if you're depressed, I would definitely recommend you seek out, a psychologist or a social worker to learn some stress management skills, or, even more ideally do a mind-body group. Impact of lifestyle on fertility, I think I mentioned already that, weight, smoking, alcohol, nicotine, let's see what else, excessive exercise. Anything your grandmother would have told you not to do, I would take her seriously, because any significant lifestyle habit can decrease your chances of getting pregnant. The real focus, though, has to be on the individual, because, for every person who's a runner who's running may, in fact, decrease fertility. There may be 5 women who can run a marathon and get pregnant while they're running the marathon. So seeing somebody else do something and get pregnant easily doesn't mean that that's the way your body works. So it might mean that a lifestyle habit that you're doing is affecting your fertility, even though a friend may be doing it and gets pregnant effortlessly. We really have to approach this from an individual basis. And I'll answer some FAQs. How long does it take the average couple to conceive? I think I mentioned earlier, 84% of couples will conceive within the first year. The majority, I think somewhere between 50 and 60%, will get pregnant within the first 6 months. So if you've been trying less than 6 months and you have no other medical issue, I would probably say try a little longer. Maybe get an ovulation predictor kit so that you can make sure your timing is right. What are the chances per cycle? For the first, I think, 3 months, about 20% of couples get pregnant per month. And the longer you have been trying, the less likely you are to get pregnant on your own. What could we be doing wrong? It's sort of tough to have sex wrong. As I said, positions per se don't tend to be a factor. I think the one thing that people can be doing, quote unquote, wrong is making love at the wrong time. If you have a 35-day cycle and you're only making love around day 14, it's probably too early. Again, if you're then also making love after you ovulate, if you have a shorter cycle and you're missing the window and you're only making love 2 days after you ovulate, you're not going to be able to get pregnant because the egg just doesn't survive more than a day. So if you've been consistently timing it right and you're not pregnant within 6 months or so, it may very well be time to be seeing an infertility doctor, although you also want to be looking at your lifestyle habits. If either one of you are smoking, if you're drinking a lot of alcohol, if you're doing a lot of caffeine, if you're exercising excessively, any of those things could be contributing. And there's actually some new research, which we're writing a paper on right now, that suggests that if you're taking an antidepressant, an SSRI, that might decrease fertility in both men and women. What are the chances of miscarriage if I do get pregnant? The risks of miscarriage are highly correlated to the age of the woman. And so a young woman in her 20s, my guess is, and I don't have the data on my fingertips, it plays about a 10% chance of miscarrying, but a woman in her mid-40s is probably about a 50% chance of miscarrying. So the odds of miscarriage are tied very closely into how old the woman is. So now I would like to open it for questions. I've been talking all this time, so I'd be more than happy to take questions.
I know, and you said how much you enjoy taking questions, so I've got a couple for you. Let's see. Somebody asks, are you able to source any mind-body programs in other parts of the country, New York City, for example, or are you aware of other programs that may be like Boston IVF mind-body program?
Oh, well, no one's as good as Boston IVF mind-body.
Of course not.
I've actually trained mental health professionals all over the world in the mind-body program. And so if you go to the Domar Center website and you click on Domar Info, we can tell you which practitioners are in your area. There are quite a number in New York City who I've trained. For some reason, I've also trained a ton of people in Chicago. But we train people really all over the world.
What is the website?
www.domarcenter.com.
Great, thank you. And you had just mentioned caffeine a moment ago, and the question was regarding, is it important to limit caffeine prior to pregnancy?
I would say that, if you're a normal fertile person, there's not a lot of data to show that caffeine is going to make you infertile. There is some data that caffeine consumption, if it's higher than, moderate, can take you longer to get pregnant. There is some data on IVF patients. There was one study a number of years ago that looked at the impact of caffeine consumption, and they basically came up with a cutoff of 50 milligrams, where they found that women who drank less than 50 milligrams a day had higher pregnancy rates than women who had more than 50 milligrams. And the bad news here is that 50 milligrams of caffeine isn't a whole lot. So a cup of tea has about 40 milligrams, a soda has about 40 milligrams, but a cup of coffee can have anywhere from 100 to 600 milligrams of caffeine, depending on if you make it yourself and where you get it, or if you get it like at a coffee place. So, if you're trying to get pregnant, you probably do want to think about limiting caffeine consumption, especially if you've been trying for a while.
How is it that caffeine impacts fertility?
I don't think we truly know. I mean, in fact, there's some studies that show that some caffeine makes sperm swim happier. They get a little high on caffeine. I don't know if we know how it can affect female fertility. All I know is that this one study found this cutoff of 50 for women who are doing IVF. So I wouldn't say if you're having a couple of cups of coffee a day and you've been trying for a couple months, I wouldn't go crazy, going through caffeine withdrawal. But if you've been trying for a while and you tend to drink a fair amount of coffee, I would think about cutting back. Now, the important thing to remember is do not cut out caffeine cold turkey, because if you do that, you will go through caffeine withdrawal and you will hate me. What you really want to do is to cut back slowly enough that you don't have any symptoms. And so our recommendation is you cut back a half a cup a week. So if you're drinking 3 cups of coffee a day now, for the next week, drink 2.5. For the week after that, drink 2. For the week after that, drink 1.5 until you taper down. That way you won't have any withdrawal symptoms.
Thank you. You had mentioned before when you were speaking of IVF that tends to make people say, oh, no, not IVF. Why do you think that is?
I think people have this idea that IVF is scary and high-tech, and, that most women, in fact, in this country who are eligible for IVF never do it. And I feel like it's a real shame because, as I said, the pregnancy rates with IVF are so high. And, in fact, in Massachusetts, where we have insurance coverage for infertility, it used to be that an insurance company would make a couple do 3 cycles of Clomid, which is the pill, and then 3 cycles of injectable medications before they would cover IVF. And then a study actually out of Boston IVF and a Dartmouth professor showed that if you skip those 3 cycles of injectable medication, because IVF has such higher pregnancy rates, that women or couples who go straight from after the pills to IVF get pregnant a lot sooner and it's less expensive. So I know that IVF may scare some people, but the fact is it can be very user-friendly at this point. Boston IVF just pioneered the use of, you can measure hormones with saliva, and so women don't even have to have blood tests. The medications are far easier to give. They are the little tiny insulin needles rather than the bigger needles. And I think a good nurse or a good psychologist can talk somebody through an IVF cycle. And as I said, with about a 40% per cycle pregnancy rate, it really gives you by far the biggest bang for your buck in terms of achieving pregnancy. You also have far lower multiple pregnancy rates with IVF than you do with the other forms of treatment, because we control how many embryos get put back in your uterus.
Thank you for explaining that. We have a couple more questions. Is there any way to control, if you're trying for a particular sex of the baby, any home remedies?
It depends who you ask. Are you asking, in terms of home remedies, I have not seen any definitive studies that say that there are ways to, I think that there's some people say if you do this, you have a 51% chance of having the baby you want rather than 50-50. I have not seen any definitive data. There's a clinic in Virginia called the Genetics and IVF Institute, which does, I think, sperm sorting. They don't have a 100% success rate. I think that if you do sperm sorting, depending on if you want a boy or girl, I think the latest I saw was I think they have about a 70 or 75% success rate. There is a way to guarantee the sex of a baby, that if you do an in vitro cycle, an IVF cycle, they can actually biopsy an embryo. to see if it's a boy or a girl, and then they can only put back in your uterus the desired embryo. I think there are a lot of people who have ethical concerns about that. If somebody needs to do it for medical reasons, for example, that there's a medical condition where you know that all the boys, for example, would be affected, we would only transfer girl embryos. So if someone has to do an IVF cycle where they're going to have the biopsy anyway, then they can choose to have those embryos put back. But I believe at Boston IVF we do IVF for sex selection, but it's a bit of a slippery slope.
Understood. Another question. If you had been diagnosed with unexplained infertility and went through IVF, she's asking, should I stay on birth control forever to ensure no future pregnancies?
Okay, so she had unexplained infertility, she did IVF. Presumably she's had as many children as she wants?
She doesn't specify.
Okay. I mean, the fact is that no matter what your infertility history, unless you have two blocked tubes.
Oh, she had twins. I apologize for interrupting you. She had twins.
Oh,
yeah.
She has twins. Okay, so I would say yes. I mean, unless she has definitively blocked tubes or her partner doesn't produce sperm, no matter what her history, she can probably get pregnant. I've had a patient who at the age of 48 had a spontaneous pregnancy. We've had cases of people who did years and years of infertility and finally moved on to donor egg, delivered a donor egg baby, and then spontaneously got pregnant. Now, spontaneously getting pregnant is our lingo for having sex and getting pregnant. So I would say, your physician needs to talk to you about what kind of birth control is most comfortable for you. I know there are a lot of physicians that aren't comfortable with women in their 40s being on the birth control pill. But, yeah, no matter what your history, for the most part, you might be able to get pregnant. I can't tell you how many times I've said to a patient who's gotten pregnant after treatment, okay, I'll say, you're going to be in the hospital after you've had your baby, and your obstetrician, when they discharge you, are going to come in, and they're going to discuss birth control with you. And you can't laugh at them, because if you laugh at them and don't listen to the conversation, 6 weeks later you could be pregnant. And do you really want your kids to be 10 and a half months apart? And my patients laugh at me and say, oh, my God, I've been through infertility for 4 years, and I've done 6 IVF cycles to make this baby. There's no way I can get pregnant. And then I get a phone call from them, a number of months later saying, oh, my God, you are right, I'm pregnant again.
I can't believe how quickly the time has passed, but we've come to the end of our presentation. I wanted to thank you for very positive. The information is so helpful, but also you have expressed how I think a lot of us don't realize how possible it is when there is fertility challenges to become pregnant.
Well, according to the data I saw this morning, in couples who are trying to get pregnant, less than 2% will not succeed within 3 years.
I don't think that a lot of people are aware of that.
Then I should get up on top of the rooftops and shout it out, because people do have a reason to be optimistic. Yeah.
Good. Thank you, and thank you for ending on that note. To everyone who's joined us, remember to check your email for the presentation recording, which we'll send out within about 2 days. Dr. Domar, thank you so much for spending this time with us and sharing this valuable information with our audience tonight.
It was my pleasure, and I wish everybody the best of luck.
Thanks to everyone for attending. We hope to see you at another ISIS online event soon. Good night.